Actually, no.
Take 2, because my phone went flat.
How long is your recording there going to be?
Huh?
It's not, that you can't speak.
Oh, it's fine.
Okay.
It's only gonna be like 5-10 minutes. Okay, so I'll start again. I'll start on ventricular filling. So that's when the ventricles start filling up with heart, with blood, and fills to about 90%. 90% of the heart, of the ventricles, are filled in this stage. So we've got here in our heart, blood comes through the atria and straight through into the ventricles, because our AV valves are open. Now, why are they open? They're open because the blue line ventricular pressure is less than aortic pressure. So if atrial pressure is greater than ventricular pressure, the valve opens and blood flows from a high pressure to a low pressure. Le Chatelier's principle. So that comes in. Okay. Also at this point we've got arterial pressure, which I'll touch upon a bit more later, but basically that's going to be high because blood is just squirted out of the heart and it started refilling again. Okay. Also at this point we're going to look at the electrical activity. So at this point it's diastole, so this flat line, nothing's happening electrically. As you can see, there's no contraction, no arrows going in, no contraction until, no contraction. So we get this flat line, no electrical activity, and then suddenly we've got this peak up. So this peak up, the P wave, the first half of the P wave starts while the ventricles are finishing filling up. Okay, we'll call it the P wave. So the P wave, it finishes in atrial systole as well, but it starts here. So we'll talk about P wave. So if we're looking, this is from lead 2. So our reference ECG from lead 2 gives us our stereotypical ECG pattern. We've got our PQRST. So that's important. Okay, so we'll go with the first couple of rules as a general thing. If a depolarization, so our way of depolarization, we've got our heart. If it's going this way and it's going towards our lead, which is looking at this way. So if our depolarization is going towards our lead, we're going to have a bump up. If our depolarization is going away from our lead, we're going to have a dip down. So similarly, we're going to have, with our repolarization, we've got our heart again, and here's our lead. If the repolarization goes towards our lead, we're going to have a dip down. Okay, opposite of depolarization. If the repolarization goes away from the lead, we're going to have a dip up.
I'm 61.
Yep. Okay, perfect. We've got that in mind in the back of our head. So then we're going to go on to our P wave. So during the P wave, we're going to have atrial depolarization. So after depolarization, we're going to have a contraction. So the atria depolarize. So our SA node in our heart is located just above the right, or just on the right atrium. That depolarizes, so we'll go into it in more detail later. But basically, fully channels open, leaks in sodium. When there's enough sodium in the cell of the pacemaker cells, no, is it?
150 centimeters.
From where?
150.
Okay. Yes, it's fully channels open, sodium enters, and shortly after, when the sodium increases the charge within the pacemaker cell to a certain level, calcium channels open, calcium rushes in, and that triggers depolarization and blah blah blah. So that's our SA node. That's what initiates these spontaneous events. So it spontaneously does this, and it sets the sinus rhythm. So sinus rhythm is the healthy one. That's what keeps you alive. If you haven't got that, you're screwed. It's like, yeah, basically. and that's about 70 to 100 beats per minute. So that sets the heart rhythm. Okay, so go back to our depolarization now. So our depolarization, it goes from the SA node towards the AV node, or generally speaking, towards lead 2, because lead 2 is down here. So it's going to depolarize, it's going to go whoop, whoop, and around the ventricles and sort of cover and go towards the lead. It can't pass this sort of thing here, this line, because that's the fibrous tissue. So depolarization can't pass that, which is why it stops. And we'll touch upon that in the next picture in the Q wave. But basically, depolarization towards lead 2, which causes our little P wave spike, or not a spike, a curve. Okay. I'll also briefly touch upon, just in case I forget, the parts of the heart. So we've got the bundle of His, we've got the right bundle branch, the left bundle branch, and then we've got these Purkinje fibres. And also say that these fibres are what make this spike. So this is spiked because depolarization travels faster in fibres than in this atrial section where there are no fibres, which is why you've got a curve. I'm not sure why the T wave, we'll go into that, but not sure why the T wave doesn't obey that sort of rule. We think it might be because repolarization is slower, generally. But anyway, okay, so we've done ventricular filling, we've got rapid filling and reduced filling. So that's obviously, rapid filling is because the pressure in the ventricles is going to be much lower at the start, and then once it started filling for like a couple of minutes, well not a couple of minutes, like a couple of milliseconds, it's suddenly going to be a higher pressure in the ventricles, so it's going to be harder to fill, a bit like hysteresis sort of thing. Okay, so if we're filled, we're full. We're going to go on to atrial systole then, so that's contraction of the heart. So we mentioned here that the P wave happens, and after depolarization, we have contraction. Okay, so we can see here our atria start to contract. Okay, and basically what happens is this squeezes any blood that's in the atrium into the ventricles to top them up, just that maximum effect essentially. So during this, our atria are gonna, so that before they've contracted, their pressure's quite low. As you start squeezing them, there's gonna increase in pressure, and then obviously as the blood starts pouring out into the ventricles, we're gonna drop in pressure again. Okay, and that's similar again with the ventricular pressure. So at the start, we've got our 90% from here, from ventricular filling. Blood starts pouring in from the atria as they're squeezing. It peaks when the maximum blood has entered from the atria, and then it starts to go down again because, well, it's not increasing. Okay. Okay, at this point, or this general area, not really sure at what point generally, but this is preload. So the point at which the heart is at its maximum stretch is essentially, that's what we call preload. So as blood returns through the veins into the heart, it's stretching and stretching and stretching, and that's preload. And then just before, the more preload it has, the more recoil it'll have, like an elastic band. The more you stretch it, the faster it's going to go. Obviously, obeying Hooke's law, it's going to, to a certain degree, it's like plateau and become inelastic, which is not what you want. And obviously thinking of those muscle contractions, so your myosin, actin binding sites, cross bridges. If you've got fewer cross bridges, you're going to have, if you stretch them too far, you're not going to have many cross bridges. But if you stretch them not enough, you're going to have lots of cross bridges. So it's going to be really strong, but not much contraction. So preload and cardiac output are directly proportional, obviously up until the point where the heart becomes inelastic. So the more preload you have, the more blood gets pushed out from its elastic nature. At this point, our AV valves, so our atrioventricular valve, are open, obviously, because the blood from the atria has to enter. and our semilunar valves are closed. Okay, so semilunar valves, if our arterial pressure is greater than our ventricular pressure, then the semilunar valves are closed. So that's because if the pressure in the ventricles isn't higher than in our arteries, then this isn't going to try and push these doors open. As soon as it gets to the point where these are trying to push out, that's when the pressure overlaps, like we got here, which I'll touch upon. Okay, so this preload proportional to cardiac output, that's the Frank-Starling mechanism. Okay, all right, so we've got all that. We'll go on back to our electrical activity then. So also at this point, we're gonna have, because we know that contraction happens after depolarization, so the depolarization for our ventricles is going to start during atrial systole. So we've got our Q wave and our beginning of our R wave in this phase. So let's look at the Q wave. Also this gap here, why do you think we've got the gap there? So that's because we've got a little bit of distance to travel. So, no, not distance, sorry, a little bit of time for this depolarization to filter through our AV node. So this AV node sort of acts like a checkpoint here. So that's that distance between P and Q is the time it takes for it to go through our AV node. So, Q wave. We've got depolarization, we've got a dip. So that must mean, looking back at this, it's going away from the lead. Okay, so have a look. It goes, our depolarization is passed through the AV node. It's going to go down our bundle branches. And we've got something weird here. So our bundle branches, our right bundle branch doesn't really have any like coming off, but our left one, we've got fibers that go into the center of the septum. So what happens is this depolarization, it goes through like these branches of the bundle branch, of the left bundle branch, and it goes towards the septum, I think it's called, might be wrong. But essentially this is in the opposite direction to lead to, which is why we get this little mini spike down. And again, I said earlier that we got this spike because it's traveling through fibers and it's faster. Let me just check it's recording because I don't want to carry on if it's not. Okay, perfect. Oh my god, 12 minutes. Why have I waffled for this long? Okay. Alright, perfect. So we've got our Q wave. That's coming this way, a little bit away from lead 2. It's only a little bit, like there's not many going towards that way in comparison to all the things going that way. So it's only a little spike down, but still a spike down. Okay. So another thing to note, our AV node is a pacemaker sort of hub as well, and this sets a beat at 40 to 60 beats per minute. Not sure quite yet on the clinical sort of relevance of this, what happens when our SA node doesn't work. Is it our AV node that takes over and suddenly we've got a lower rate? I'm not quite sure yet. That's something to look at, and if I don't know in the future, then look back at this. Okay, we then got our R wave. So again, we're continuing with this depolarization of our ventricles, and this is all in atrial systole. Okay, so our R wave, so it's a spike up of depolarization. This is the same as the lead direction, means it's a spike up. So we got depolarization in the same direction as the lead. So it's going that way, okay? Which is what we see here. So we've got this green representing our depolarization, going towards the lead, going through our Purkinje fibers, and towards our lead. But you might be thinking, well, actually it's going this way as well. What's this? Well, I'll touch on that. So this bit, so in our right ventricle, the wall is, well, our left ventricle is 3 times the size or the thickness of the right ventricle. So basically what we're saying is the right ventricle doesn't matter. This is irrelevant in terms of like what we see on our ECG is overpowered and overshadowed because this is more prominent. So that's what we'll see. Also, similar sort of reason here. So at the same time as ventricular depolarization, we've got atrial repolarization. Okay, so if we look here, repolarization in the opposite direction as the lead, we've got a spike up. So you might think, well, where is this on our sort of on our ECG? Because the atria are smaller in comparison to the ventricles, we're not going to see it as much. And even if we did, it's the same sort of direction. It's still going to be a peak up. So we're just not going to see it. Maybe if there was no ventricular repolarization, I imagine you'd see the atrial repolarization, but again, you're not going to see it on the ECG. Yeah, okay, perfect. All right, then we'll go on to isovolumetric contraction. So this is quite important. As you can see, a couple of things happen in this stage. So basically, it's isovolumetric, so same volume and contraction. So we know our ventricles have depolarized, our atria have repolarized, so our atria are ready to fire again, but our ventricles aren't ready. So they've just been depolarized, they're sending an action out. So immediately after depolarization is a contraction, and that we'll touch a bit more on that as well in another video, but essentially sodium enters, imagine an axon sort of action potential. Our sodium's entering and it's leaving, and then blah blah blah, and it's like a domino effect. So as this domino effect of sodium's happening, calcium is happening just behind it, and having a similar sort of effect. And we know calcium is for contraction, so that's why our contraction happens straight after depolarization. Okay, so we then got isovolumetric contraction. So this is a very small time period, and it's just before ejection. So this is sort of the phase literally just before we eject our blood. And that's because in our ventricles, once we've filled it with blood, we're still going to have a little bit of air. So when our ventricles are contracting, we're going to have a bit of time, like a little bit of time, a very, very small bit of time, where our ventricles are contracting and nothing's leaving because they're still squeezing the air out. Think of like a ketchup bottle, and the ketchup's at one end and you're squeezing. So you're squeezing the air out first and then the ketchup comes out. Okay, so look at the pressures now. So our ventricle pressure's decreasing, and then it gets to a point where it starts increasing again. That's because it starts contracting. So our ventricles start contracting, our pressure in the ventricle starts to opposite of plummet, spike, which is understandable because it's being squeezed, so the blood's bouncing around in there and wants to escape. At this point, it crosses the atrial pressure. So if our atria pressure is less than our ventricle pressure, then our doors to our atria are going to close because the blood's sort of pushing against it. You can imagine the door's like this, the blood's rising, and then suddenly it's closed. Okay, that's important. So that is our S1 sound, our lub. So you only hear a heart sound when you slam a door. Essentially, you don't hear, like if you open a door, you're not going to hear it, but if you slam it, you're going to hear it. So that's why you hear a sound. Pressure increases in the ventricles, all the while no blood's leaving, until we get to the point where the ventricle pressure is greater than arterial pressure. So we get to this point where our pressures again overlap. So that means the pressure is great enough to open the semilunar valves. So this is sort of like on the border of this like dotted line. This is more in the rapid, it's like just before rapid ejection. I've sort of drawn it a bit off, but it should be like just on that border. Okay, so we'll touch upon like our semilunar valves will open at that point because the ventricular pressure is greater than our arterial pressure, so it is going to push our doors open. Because our doors are like that, other doors like that, they're going to push open like little floodgates. So here, AV valve closed, semilunar valve closed for the most part, but it opens at the end of this stage. But once it's opened, it's no longer isovolumetric contraction because volume's changing. Okay. In this phase as well, we've got our S wave. So again, that's depolarization. So if we've got depolarization and there's a dip on the ECG, that means it's the depolarization is traveling in the opposite direction of the lead, so away from the lead. So if we look here, here's our depolarization of our S wave. So again, we've got our heart. Depolarization is happening at the very ends of the Purkinje fibers, and these ends are sort of pointing towards the atria, so it's going to be away from lead 2. So again, similar to our bundle branch depolarization, there's only a little bit happening. It's just at the very tip of the Purkinje fibers. So we're going to have a very small dip. Well, I say small, but it's going to be smaller than our R wave. So we've got our S wave, and it's a spike again because it's a Purkinje fiber. It's going to travel faster, like a copper wire versus going through my hand. It's going to be better through a copper wire than electrical traveling through my hand. That's just how it works. Okay. Oh, I almost forgot. Last thing from this bit is our C wave. So our atrial pressure, you'll notice, sort of spikes again. Atrial pressure spikes again, and this is called our C wave. So this is because our atrioventricular valves, they're going to be pushed back into our atria. So as the blood is increasing, you can see it's filling up, it's being pushed up, and our atria are sitting on top of our ventricles, and they're pushed. This is the ventricle, this is the atria. The ventricles is going to start pushing up and push the valves into the atria. So what's that going to affect? So it's going to affect our volume in the atria. All the while, keep in mind that blood is still pouring back into the heart. Blood doesn't stop coming into the heart, it's going to keep coming. So our volume of the atria, because it's being squished, is going to decrease. But we also know that blood is still coming back. It might be trickling, but it's still coming back. So the volume is going to be decreasing even more. So that's why basically we've got a pressure increase, because our volume's decreasing, and we know that if you decrease volume, you increase pressure. That's just something you know. Can't remember the law. Okay, we'll go on to ventricular ejection then. So we've got rapid and reduced ejection, which we'll go on to. So in this phase, we've still got ventricles contracting. They need to contract, otherwise the blood's not going to leave. You've still got to squeeze it. You don't stop squeezing your ketchup bottle just because the door's open. You keep squeezing it. Okay, so at this point, AV valve's closed. We know that because of our S1 lub. Semilunar valve's open. We know that because the pressure's overlapped here. So on this line, it's open. So in this phase, it's going to be open. Okay. Blood flows from a high to a low pressure. So at this point, our ventricle pressure is higher than our arterial pressure, which is why we're going to have rapid ejection. So a little subtle difference here. So because the blue line is above the green line, we're going to have rapid ejection. And that's because, think about it, if we've got, say 100 psi and 5 psi, pressure's going to go faster over here. But if we've got 100 psi and 90 psi, it's still going to go over there, but slower. Okay, keep that in mind. It's going to go up there, blood's going to squeeze out, and the reason it keeps getting ejected still is because our ventricles are contracting. So it's still going to squeeze out, you know, just because maybe the arterial pressure is higher, it's still being squished out, so it's going to go, and it's got momentum as well. So the momentum of the blood will keep it going for a bit as well, until we get to this point as well. Okay, so we've got at this point we've got the fact that it's a higher pressure in the ventricles than the arteries, so it's going to rush out and it's being squeezed. At this point we've got its momentum and its and the fact that the aorta and the vessels, the pulmonary artery, they're quite compliant. So that means they're stretchy essentially. Check again if this recording is done.
Is it you eating?
Right. Yeah, I'll eat some.
What are you having?
Cheese.
I was going to fry some mushrooms
Yeah, I'll have whatever.
and egg.
We can have some
together.
macaroons in a minute as well.
Shall I just do fried mushrooms by itself and then do cheese and crackers and stuff?
I'll eat whatever. Egg sounds good.
Okay. With what?
Toast? I don't know. Just I don't mind actually. Just whatever. Whatever. Yeah, surprise. Okay, so our aorta and our pulmonary arteries are very compliant. So that means they're stretchy.
Yeah, so I don't want to eat them.
So blood flow, it occurs steadily, even though our artery pressure is greater than our ventricle pressure. So think of it like this. Our blood's coming out. It's coming out of this pulmonary trunk, and the pulmonary trunk is stretching out as it's coming out. So blood's hitting it, it's going out, and then it's stretching,
What, dripping there?
and then as it stretches, we know because it's elastic, it recoils. That's the compliancy.
Yeah.
It recoils and it stretches and pulls it back in. So it's almost like drifting. So blood comes out, whoop, and then bang, like a slam dunk. It goes whoop, bam, bam. It essentially gets pulled around this corner. So on this bend, it sort of gets pulled in and pushed around, which gives it speed. Essentially, it's like a little power turn. But it's also happening in this trunk as well. So think the blood's hitting that and it's going to bounce back and try and go back into there. So there's a point where the blood leaving via normal circulation is greater than the blood trying to get back into the heart. But then there gets a point where the blood trying to get back into the heart is going to be greater than the blood actually going to the rest of the body or the lungs. Okay? And that's our dichrotic notch. Okay?
Yeah.
So, at our dichrotic notch, that's sort of in the next section actually. So dichrotic notch sort of happens in isovolumetric relaxation, but keep that in mind. Okay. So again, remember, blood keeps coming back into the arteries, the atria. They're not going to stop. So that's why we've got a gradual increase of atrial pressure. And then we'll look here at our electrical activity. So we've got quite a bit of flat line, and that's because nothing's happening. Nothing's happening electrically. Because our ventricles are still depolarized, like this. They've just depolarized. So the contraction's following. That's still happening until sort of the end of this phase, where our T wave starts to form. So our T wave is our ventricular repolarization. So that's resetting our ventricles, ready to be fired again. So our atria, they've repolarized in our wave, so they repolarized here. So the atrium are ready to fire again, but they can't fire if our ventricles aren't ready. So this needs to happen, it needs to fire again.
You're off now, is it?
Okay. So, repolarization. Why is it a peak up? So, if we thought, well, our depolarization is happening towards the lead, repolarization is going to happen away from the lead. And we know if repolarization happens in the opposite direction as the lead, we're going to have a peak up. Okay? Now, I think we'll have to look at this, but the reason this isn't a spike like our QRS is because repolarization maybe happens slower. Otherwise, I can't really find a reason. because in theory it's going through the Purkinje fibres again. So it should, in my head, it should go the same speed as it would to depolarize, and therefore be a spike, like a sort of like that, like a T. But it's like that, so I don't know. I like that then. Nice new finish. Okay, so where were we? We got the start of T-wave ventricular repolarization, where it's going this way, and so we got our rate. Okay, perfect. So that's all our electrical activity. T-wave finishes off there, but that's the gist of everything you need to know, ECG wise. Okay. What else do I cover that? Yeah, so blood flows out there. At this point as well, our AV valves, they're still closed because our ventricle pressure is higher than our atria pressure. Okay. So they're still closed. Our semilunar valves obviously open because that's our sound there, our opening at this point. Finally, we've got our last phase, isovolumetric relaxation. So in this phase, we're going to hear our S2 sound, our dub. Okay. So I mentioned the dichrotic notch. So our blood is trying to come back into the heart. Okay, and it's trying to come back into the heart at a rate faster than it's trying to leave and go to the body. So at that point, our valve is going to close. So if you think about it, blood is trying to come back down the pulmonary artery or the aorta. It's trying to come back, and because our valves, they're one way. So if blood starts coming in, they're going to close like that, like Tower Bridge. So because blood builds up here and it pushes, builds pressure and it closes it. It's like a little pulley bridge. Okay? And that's what's going to happen. So our atria, our valves, our semilunar valves are going to close. Okay? That's our S2 because heart sounds only when you close a door. When you slam a door, it's going to cause a sound. Okay, perfect. We've got our dichrotic notch, dichrotic wave then. If you think about it, if we slam this door now, we've got all this blood trying to bounce on the door, and it's going to rebound and the pressure's going to increase because it's trying to break in, but it's not going to go through. So we've got blood hitting a wall and rebounding off. And that's our dichrotic wave, where it's sort of a wave of pressure. Of our arterial pressure. In this phase as well, obviously our ventricular pressure is going to plummet because there's no blood left in the ventricles. So ventricles are empty, all their blood's gone, and nothing's filling it back up. Until, obviously, the pressure is going to plummet so much that our ventricle pressure is going to be less than our atrial pressure. And at that point, because we've got pressure in our atria is bigger or larger than our ventricles, and pressure goes from a high to a low, Le Chatelier, then our blood is going to flow in as like that, basically. So all the blood that's been pooling in our atria, so our blood keeps coming to the heart because we know that because of this little gradual increase. Pressure, blood keeps coming into the atria, and then eventually they just empty, like a little waterfall, they empty, blood pours into the ventricles, and then we start the cycle again, where all the blood that's coming back to the heart just goes straight to the ventricles, and it starts filling. Yeah, so at this point, AV valves closed, semilunar valves open. At that point, our isovolumetric relaxation AV valves are closed because they haven't opened yet, and then our semilunar valves also close, which is our S2 dub. So important things to note from this diagram: S1 love happens in isovolumetric contraction. S2 dub happens in isovolumetric relaxation.
A for the fork.
And the cycle happens again. The rest of ventricular depolarization happens during here, and then we're ready. So here we've got diastole, relaxation of the heart, and ready for it to fire again. Okay. Two final things to note then. We've got inotropy during isovolumetric contraction, so that's relating to cardiac contraction and emptying. So you might have an inotropic drug. So positive inotropic drug will stimulate contraction of the heart and emptying of the heart. So that's what we call an inotropic drug. A lusitropic drug, or lusitropy, is relating to cardiac relaxation and filling. Okay, so opposite of inotropic. So a positive lusitropic drug would stimulate relaxation of the heart. So that might be beta blockers, things like that. Perfect. I think that's it. Perfect.